Thank you very much, Karen and Kate. And may I say that Peter Lees is looking amazing for his age. I really had no idea. We've talked about the need to learn from elsewhere in the world, and our next speaker is in a perfect position to help us. You've heard much about his work from Kate already. He is the Professor of Health Policy Management and Evaluation at the University of Toronto, and his work has focused over the years particularly on improving patient safety. I'm delighted to introduce Ross Baker.
Thank you very much. It's a real pleasure to be here in London and to be part of these conversations. And this conversation is going on in many different countries in the world about how do we engage leaders and clinicians to create high-performing healthcare systems working in partnership. And I had the privilege really to work on this question for several years at the request of the Ontario government as they were making a restructuring of their system and asking the question, so what kinds of investments should we be making to ensure that as we restructure the system we can move it towards higher quality performance? Chris asked me to return to this work, most of which happened 4 or 5 years ago, to refresh it and to look particularly around the lessons for leadership and the roles of leaders in high-performing healthcare systems, to draw out some of the ideas and lessons that we have learned from these systems to see whether or not this could inform the initiatives that you're undertaking here in the UK. And as I said, these are common themes across many different systems. Everybody's worried about this conundrum of how do we contain costs and maintain high quality of care. And as we look at the literature, although there's a lot written about high performance, from a clinical perspective, it tends to be very focused. So we look at a high-performing surgical team, or we look at a high-performing family health team in the community. And those experiences are valuable and interesting, and they give us a perspective on that particular slice of life, but they can be, in these larger settings that they're in, only islands of excellence in a larger sea, which includes other islands which are not so excellent. And that's not so helpful for you to know that the trust that you're in has excellent maternity care when you've had a heart attack. So the issue here is, how can we think about excellence as a system issue? How can we focus in on the integrated series of services that provides largely excellent care? And the other perspective, which is the national perspective, where we compare England to France or the United States, gives us only a sense of the flavor of the policy and the impact of policy, not on the execution at the intermediate level here, the healthcare system level that builds from the microsystem and creates a high-performing, integrated regional system of care. So our challenge, which we labeled this project Quality by Design, was to understand and investigate regional systems anywhere in the world that had seemed to create high performance across many different clinical areas. And we weren't so naive to think that it was possible to do everything at the very best, but we thought it would be interesting to find places that seemed to be characterized by a high sense of commitment to high performance, and were able to deliver on that. And then to go back and ask the question, and many of these have been doing this for 15 or 20 years. What was the essence of the formula that it took to get there? What were the leadership decisions? What were the strategies, investments that it took to move forward? Now, others have been down this path, and so as part, being a good academic, we went to the literature first to see what other people had written. And I'll just take a couple of examples from this to give you a sense of the issues and some of the critical things that need to be focused on. Ewan Furley and Steve Shortell a decade ago talked about what does it take to implement successful quality improvement in healthcare settings. And as you see, none of this seems surprising. Leadership at all levels, a culture that supports learning, the development of teams, greater use of information technologies. John Overveit and David Gustafson took that list and they added some additional things to it. And we wouldn't disagree with any of these either. Physician engagement, sufficient resources, program management and training, and a strategic focus on patients and customers. The problem is, of course, if the answers are so clear and everybody nods their head and says, yes, that's what it is that we have to do, why is it so difficult to actually put into place? We know that we're not going to be successful unless we do these things. And reflecting on this, I think the answer is that none of these things are easy. We take each one of them and they're a challenge in themselves. How do we bring physicians to the table in a way that will meaningfully engage them and take their insights into the redesign of safer systems? How do we ensure that the information flow is going to support not only the daily decisions of individuals, but the system-wide decisions about the path forward that we need to take? So these attributes are complex and difficult to do. Their impact is often interrelated. Having one or two of them is probably not sufficient. And putting them all together is obviously a huge task. So we wanted to find out if there were places that seemed to be much more successful in this and to look at what they had done. And I heartily agree with the comments just made about the nature of leadership as being something that is not just an individual characteristic, something that we look at in terms of the person who sits in the chief executive role, but something that characterizes whole systems. And it's the role of senior leaders to create a system where everybody feels engaged and sees the leadership challenges in front of them. And I'm not the first one to say this, and you see some people who have written at length on these issues, but I think this is an important issue. How do we create the mindset and the skills to help create whole systems that are focused on improvement? Now, part of the challenge we faced was that we wanted not just to look at the US, because when you sit in Canada and you come back with American examples, people say, yes, well, we can't afford that, can we? And we didn't want to just look at European examples. We wanted to blend. And so immediately you face this conundrum is that there's no good measurement set to allow you to choose between regional healthcare systems across all those different areas. And so we did the next best thing, which was to ask the people who should know, who have traveled widely and have deep skills in this area, where should we go to see highly performing healthcare systems? So we asked Don Berwick and Steve Shortell and others in the US. We asked Helen Bevan and others in England. We asked Michael Bergstrom in Sweden. And they nominated a fairly short list of places in Europe and largely in Europe and North America. And we ended up choosing five systems in 3 different countries. Jönköping County Council in Sweden, which 10 years ago nobody had ever heard of and now is on everybody's lips as one of the places to go to as you think about high performance. The Henry Ford Health System based in Detroit, Michigan. Intermountain Healthcare, which serves half the population of the state of Utah. The Veterans Health Administration is a particularly interesting and important example for us in Canada because it's a government-run system with a huge bureaucracy at the top, but managed to go from worst to first in many areas in the U.S. in a relatively short period of time. And we in Canada, who live in a government system hugely bureaucratic, would love to know how they did that. And we went to England to look at Birmingham, the Birmingham East and North Primary Care Trust and the Heart of England Foundation Trust on the recommendation of several of our key informants over here. And then we had an advisory committee and they gently said, well, this is all well and good, Ross, but are you saying there's no place in Canada that we can learn things from? And you know, sometimes you realize right away at the folly of that kind of assumption. So we immediately replicated this process and picked 2 places in Canada that we thought we could learn things from as well. The advantage we had was that these were diverse places. So you couldn't say it was the English national policy that was responsible for high performance, and you couldn't say it was the lack of much regulation in Sweden that was responsible for performance, because these were systems that did well when other systems in the same environment were not performing at the same level. And as you can see, they were diverse in other ways as well, in terms of their geography, in terms of the kinds of patients they saw. But underlying this, there were, we think, some common elements of the DNA, which I want to talk about. And they were not advantaged. I mean, nobody could say that serving individuals in the heart of Birmingham is an easy thing to deal with. It's a challenge. Similarly, Henry Ford is headquartered in the part of Detroit that was destroyed by the riots in 1968 and really hasn't come back from that. So they face this enormous burden of $100 million a year in uncompensated care to residents in their city who don't have health insurance. So these are systems that have risen to the top, not because of the luck of geography or population, but because they've done the right things. So we went out, we looked at the literature, and then we did site visits to these organizations where we take a team for 4 or 5 days, talk to the senior leaders, talk to people in various systems within these organizations, and then wrote detailed case studies, which have been published and are available in a book that we put together in 2008. And then we've been doing a series of cross-case analyses to bring out the lessons from this. So what I want to do is say a little bit of what are the key elements of high performance as we saw it, and what are the roles of leaders in that. So this is, these are the key themes that emerge from this, and I'll go very quickly through this, then I'll come back and sort of drill down on each one of them. And the top one is really this notion about consistent leadership with common goals and aligned activities. And it looks like an easy thing. I think it's a very challenging thing to do because the complexity of healthcare is such that you need to bring in a wide range of different skills and experiences, and that means leadership teams need to coalesce and figure out how to work together. These systems focus on quality as a core objective and sometimes as the really leading objective. They build capabilities through the organization, not just in leadership skills, but in understanding how to improve care. They have robust primary care at the heart of the system as the platform on which they deliver the full range of services. They engage patients in their care, and they use patients as a way to redesign the system. They promote professional cultures that support teamwork, continuous improvement, and patient engagement. They think about the intersection of the various programs and organizations, and they work to bridge those gaps to build more effective care transitions. They think about information and they use information. 2 of these systems are among the leading systems in the world in the use of clinical information systems, but others have done well by more rudimentary and manual means. And they have effective learning strategies and methods to test what they want to do and to scale it up from each clinical unit to the broader system. And lastly, and I think really interestingly, the role of leaders as creating an environment that hears the larger policy and system directions, but is able to buffer that in a way that supports what happens within the system. So I'm going to say a little bit more about each one of these with a few examples, and then I'm interested in how this hits against your own experience and the questions that you have. So high-performing healthcare systems have long-serving leaders. Sven-Olof Carlson was the chief executive in Jönköping for about 18 years, and he served with the chair of the county council, who was an elected politician for almost that entire period. And he retired a couple years ago and was replaced by Agneta Jansvir, who had worked in the system. She had left and taken another position and then come back. So you have this pattern of 20 years of a similar view and understanding of the system and the core skills necessary. The same is true in Henry Ford in terms of their leadership. Same is true in Intermountain. They've had 2 chief executives over a 20-year period. And so one can argue that sometimes leadership should change because we need fresh skills, fresh perspectives. But systems that are working well, that have this governance responsibility to figure out how they continue to hit on all those cylinders. And it's not just leadership at the top, although that's, I think, critically important. It's leadership throughout the system, partnerships with clinicians, particularly doctors, to make leadership more effective. So the second piece of this is, what do leaders do? And I've already said this. I think that because healthcare is so complex, if you look at strategic plans, most organizations have strategic plans that have 8, 10, 12 different objectives, often conflicting in the kinds of things that organizations need to do. And their resources get stretched over that wide sort of range of activities. If there's something that really hits you when you visit the leadership teams on this, is that they have this drumbeat of focus on quality and system performance that really gives them a clear view of the way to move forward. When we went to Jönköping and we heard about this, you know, everybody mouths the same words, and it's only when you go down into the organization and you ask people what their job is and how it relates to the larger system. At Jönköping, people would always return to the same phraseology. They'd always point to the same picture of the strategic plan. And it gave a sense that, in fact, the whole system saw this as a critical issue moving forward. Intermountain has had the blessing of being one of the places where, as I said, patient information systems have been very advanced. But Brent James will tell you that they only really derived the value from that when they linked the information systems to this knowledge about what does it take to improve care at the front line, and they engaged clinician leaders within their system and gave them the tools and the training to use that knowledge to work well in the system. So Sven also have already mentioned, says that quality is something that needs to be linked to the other goals of the organization. And the leadership team needs to figure out how to create an integrated view of their responsibilities. The chief financial officer, the chief nursing officer, the chief medical officer all need to talk in the same terms and share similar goals. And to achieve that, one has to build capability within the system as a whole. And I don't know much about the kinds of investments that happen in England. I've been impressed by the work over the last decade in terms of building skills in frontline staff. But I can tell you in Canada, and this is true to some extent in the US, we really sorely underinvest in our clinicians and other staff in terms of building skills to help them analyze and improve the care that they work with. And so a system that does well is a system that invests in building capability throughout the system. And this little picture is the Kulturum in Jönköping, which was built as a place to develop system-wide capabilities. And every day it fills with teams of people across the system who are working on asthma care or improving the flow in surgery or whatever the issues are, bringing people throughout the system, giving them the tools, and then putting them to work on projects. So now a majority of people in Jönköping have had this experience where, as frontline clinicians, they participate in working on the care in their system. And recognizing that, that they need to move back up the value stream, they're now working with the nursing and the medical schools, and Paul Batalden is leading an effort of interprofessional development around the improvement of care in the Jönköping County area. And in addition to the clinical improvement skills, there's these issues about leadership skills and the ways in which leaders work together. Intermountain developed this program 15 years ago under Brent James's aegis called the Advanced Training Program. You cannot take a senior leadership job in Intermountain if you have not been through the Advanced Training Program, whether you're a clinician or whether you're a non-clinician. So everybody learns the same issues, and it's not just about quality improvement, it's about the healthcare system and the complex series of regulatory and other barriers that are facing leaders on a day-to-day basis. Everybody speaks the same language, they learn the same tools, and so think about that in the context of the leadership teams that you're working in. I know in Canada, what we discover is that everybody comes with a different mindset, a different set of the things that they think are most important. And so the work around the leadership table is a negotiation process rather than a common problem-solving process. So I think this sort of advanced training program where we bring leaders together and give them skills so they can work together is really effective. And we look to England for experience in primary care from North America, so I can't probably add much to what you've done here, but I think the primary care system is the fundamental bulwark of the whole healthcare system. And as we look at these systems, they have worked really to build this up, taking their existing systems. The Veterans Health Administration in the mid-1990s under the leadership of Dr. Kaiser worked to take programs out of the hospital and to create an integrated system linking clinics in the community to hospital-based care, creating the framework on which they could develop high performance. And Henry Ford, conscious of the huge population health needs that they face in their population, did the same thing, developing a series of primary care clinics around the Henry Ford and the other hospitals that are part of that system. But it's more than just creating structures. It's creating a sense of how to operate within those structures and how to manage the relationships between different levels of care. And one of the most, I think, insightful things that we saw in Jönköping, which is now being copied in many different places around the world, is this notion about framing the design of care around the experience of patients. And Mats Borstig and others at Jönköping made up this person, or really a composite person, called Esther. And you read a description of who Esther is. And as they redesigned the system and they brought clinicians from the hospital and the community together, they discovered that everybody knew well what they did and valued that and saw that as really important. And so the conversation was not a dialogue, it was just an exchange of views. But things broke down when they started to pose questions about what's the best care for Esther and how do we ensure that Esther will be able to stay in her home while getting the care that she needs occasionally when she goes to the hospital and away. So we're thinking about the system, not from the perspective of doctors in the hospitals or nurses in the community, but from the perspective of Esther. And this is a Swedish diagram of the various parts of the system that are now revolved around Esther and the ways in which those parts fit together. And if you speak Swedish, you might understand it, but I don't. On a higher system level, one of the things that Intermountain has done, which I think is really quite remarkable, is they reorganized their entire system around clinical programs, taking analysis of the experiences of their patients and then building what they call clinical integration teams that pull the data, understand the existing best practices, and then work to continually update that. And so they've organized care at Intermountain, not based on functional structures, but based on clinical programs with local representation in each one of their hospitals and regions that serve to translate the emerging guidance in this area into practice. The next issue is this issue about professional cultures supporting improvement, teamwork, and patient engagement. And again, it seems like something that is very obvious and straightforward. But if you've worked in microsystems on frontline teams, you know that the pressure of daily work and the need to keep going makes it very difficult sometimes to raise your head up and ask, so how could we do things differently? How could we work better as a team? And so again, the issue in high performance is to create a space for members of these teams to figure out how to do these other things. And very few people until recently, very few clinicians or managers really had the skills to figure out how to take evidence of effective clinical practice, understanding what it takes to be an effective clinical team, and take the skills of quality improvement and meld those together in a way that creates highly effective microsystems. I have a quick story that comes from Henry Ford a decade ago. And a decade ago, as the Institute of Medicine in the U.S. Was about to release their quality chasm report, which really sort of galvanized this sense that we needed to move healthcare in the U.S. to a much higher level. Henry Ford was working on an application to be part of the Pursuing Perfection project that the IHI and the Robert Wood Johnson folks were putting together. And so they were looking around their system about where they could identify opportunities to improve care and be much more focused on this. And Dr. Ed Coffey in the Behavioral Science Division said, you know, I don't think we should tolerate any suicides among the patients who come here to Henry Ford. Every suicide is a failure. And his colleagues pushed back a bit because actually Henry Ford was already better than average in this area. And they said, well, you know, we got lots of stuff we could focus on. Why would we focus on suicide? But they decided, Coffey convinced them, and I think they must have been all well convinced as they worked on in evenings and weekends to come together and to redesign the behavioral health system, focus on this idea that they could not manage this problem alone. They had to manage it in the context of primary care providers and others within the system to recognize when people were at risk of suicide, to intervene where necessary, and to build skills among general practitioners who could then work with these individuals in a system that didn't reward people for spending a lot of time in their clinical encounters. And so they worked for several years on this, and they had this amazing breakthrough, moving from, as I said, already below average performance into really extraordinary levels of outcomes, and winning recognition from a number of prominent American organizations in the result. The governor of Michigan declared a day, the Blues Busters Day, across the state of Michigan in recognition of the achievement of just this one team. Now, as I've already pointed this idea about integration and the importance of thinking about care not just in the terms of individual microsystems, but across microsystems and across different organizations. And we all know this, that the challenge in the current environment is to create value-based strategies that link the work in different parts of the system and figure out where should the clinical work be done, and can it be done, does it need to be done at all in a formal encounter, or can be done through electronic means or through the telephone at home. But redesigning systems along this path are obviously very difficult, and referral processes often don't help us because they simply transfer the patient and transfer the knowledge without providing people with a view of the whole system. So high performance, and all systems struggle with this, but I think some of the things we saw in our examples showed the way forward about this. And again, going back to Jönköping, their experience is that because providers don't see the world through any eyes except the eyes of their daily experience, that they needed to pull together people who represented this value stream and then map out what it meant for the pediatric asthma patient or for Esther in her home, what the value stream looked like and who should be doing what where. This working across levels only can happen if people have a larger view of the system and the capability of their colleagues who work elsewhere in the system. And we in this 21st century we lament that healthcare is not as advanced as banks and airlines and other industries that use information effectively, and so it's a pretty commonplace notion now that only when we get those kinds of tools will we be able to provide the kinds of care that really we expect. And in fact, we went to Intermountain and the Veterans Health Administration, who partly through luck, because they had people within their organizations 25 or 30 years ago who saw the power of the early computer systems in translating written records into electronic records, have now the benefit of these very sophisticated information systems. But that's not true everywhere. And at Jönköping, where they were working to develop an electronic record when we were there, they said that's not the case. And so now we identify what information is useful for our teams as we go forward, and how can we gather that in small enough samples that it doesn't slow down the work, and what resources do we need to put in the clinical microsystem so they not only have a view, the doctors not only have a view of what this patient's issues are, but what all my patients with similar conditions deal with, and what is the system we're doing with this. So I think the underlying thought here is to figure out how to integrate knowledge into the decisions we make about the design of care, and how to flow that across the system so that everybody, regardless of their responsibility, sees that in a clear way. Brent James, I've already noted this, although they had people in the late 1960s working on the medical record, their real progress came when they linked that medical informatics expertise to the underlying skills about improving care and engaging clinicians to examine their own processes of care and to move forward on it. Strategically, they've started to look at what areas, they have for some years now, started to look at what areas they need more sophistication, more information, because even within Intermountain there were areas that weren't fully computerized, and so they're now using this notion about working backwards from the data that individuals will need at various points of the system to a question of what the information design should be in the system. And this is an old slide, but it makes the point that we often think about clinical information systems as being most valuable about making decisions for individual patients. But the reality is this information needs to be cut and diced in various different ways. So we need to ask about all the asthma patients within a practice. We need to ask about the asthma practices across the different parts of the system. And then we need to look at those asthma patients who suffer multiple morbidities to ask whether or not we're dealing with this. And Intermountain has the capability to do this, to manage on a close to real-time basis the strategic level of information that comes out of their system. And then to take ideas, to learn about them, and to scale up. And we were very impressed, both in Birmingham and in Jönköping, with the clear sense of design from individual micro-unit experience into the larger systems of care. So learning from individual practices as they do quality improvement is great. It's the fundamental building block of everything we do. But if we have to do this practice by practice, all right, we're never going to get to high levels of performance. And so the work that the NHS Institute has done on their spread and sustainability strategies, and this notion about working small scale, testing at a concept level, and then building larger and larger systems using these effective practices, I think is an important way to move forward. Birmingham also gave us some real insights about borrowing from other systems and taking examples from the U.S. And from private industry, and then integrating them into the design of care in Birmingham. And I have to say, in Canada, we have a reluctance to think sometimes that we could learn from for-profit healthcare, but at the same time we have to ask the question, how do we take what they do and make it viable in our environment? And what we saw in Birmingham, I think, gave us some great examples of the ways in which high-performing healthcare leaders do that. And it's now common for people to participate in programs, of training programs and various projects, but these places had been there early, engaged with thought leaders in the field, Don Berwick, Maureen Bisignano, Helen Bevan, and others, who were really seeing the path forward and then asking, so how can we be involved in this? So these were all systems at the front edge. Ironically, the one place we didn't see this was Intermountain, and so I said to Brent James, this was when the 100,000 Lives campaign was under full, are you engaged, fully engaged in the 100,000 Live campaign, thinking that he would tell me about all the different teams he had. And Brent said, well, you know, those are all important issues that they're working on, but we actually solved those issues a couple years ago, and so we've moved on to other things in our system that we're focused on. But our people who've done that work, they're helping the IHI to carry this out. So. And that raises a series of issues, because high-performing healthcare organizations are not average organizations. They're organizations that have really moved to a different point of the learning curve. And our broader policy and regulatory environments are really trying to deal with the average experience of healthcare systems. And this raises an issue, because accreditation in North America is this enormously complex and costly process that healthcare organizations need to deal with. And the argument is that this is a quality mechanism. It moves people to new levels of performance. And what we saw in Intermountain and Henry Ford was, in fact, they were required to go through these processes, but they had developed separate staffs that buffered them from the work of the accrediting commission and the work of the state regulators, so that their quality people could focus on these new frontiers that they were engaged in. So one of the roles of leaders is really to help understand what the true issues for the organization, and to interpret and work with the national policy and regulatory issues, but to figure out ways that you don't lose focus on what's going to move you forward. The VA in the mid-1990s created a performance management system that helped to bring them very quickly to high levels of performance. So one of the critical things they did was really to align the goals across the system. And they started out with 20 or 30 goals. And if 20 or 30 was good, then clearly 50 or 60 was better. And if 50 or 60 was better, then 100 or 120. So they're now managing with something like 400 measures. And this is a picture of what is colloquially called the Christmas tree for the New England Veterans Network. And each one of the things which you can't read down the left is a target goal, and the color-coded results tell you green is good, gold is among the best in the system, and red are areas for improvement. And so you can see why this is a high-performing system. They're outstripping most of these areas. Each one of the columns is a different facility in this VA network. But, and this is a big but, if you're managing now 400 measures in the VA, do you have time to work on anything else at a local level? No, you don't. And I know you've had this experience here, so it's not a surprise to you. But I think the key role of leaders is to figure out not how to ignore, which would be perilous, the accountability requirements and objectives that come from above, but how to use this information wisely to not distort local activities and not to eliminate the opportunity to respond to local needs. So Gary DeGasta, who was the CEO of a small veterans hospital in northern Vermont, not far from Dartmouth Medical School, but still a long way from Washington, said, we created our own scorecard. He says, it's actually not legal in the VA to do this. He says, because everybody says you need to use the VA measures and VA strategies. And the senior leadership in the VA wasn't too happy when we wanted to talk about this. But I think it was a bit of local genius to figure out how to interpret the national objectives, the national measures, and to create a view of the system at a local level that was responsive to that, but allowed them to be focused at local issues as well. So this is a quick Cook's tour of really a complex series of issues across very different systems. But the issue or the conclusions that I have are really that investment in leadership is not just an investment in individual skills. And these high-performing systems brought out, I think, the best in these leaders, but they also saw the need to continue to invest, to bring people forward, and to have a long sense of what the game plan was. So it wasn't, although they had yearly strategic plans, they were really dealing in plans that focused on a decade or 2 decades work. Because you can't, there is no magic bullet here. There's no one way you can move from modest performance to high performance in a year or 2 years. And people who tell you that, I think, are mistaken. You can do things at a local level that will change the performance of local systems, but bringing that through whole large systems, and it takes a long period of time. The good news is that the investments are really upfront, and if you're successful, they start to pay off. So Jönköping has had this long, slow, steady pace since the mid-1990s. They now pay for all their training. They pay for all the clinical improvement work that they do, including the cost of covering staff who come out to work on these teams, by the recoveries they've made on previous projects, right? So it pays for itself if you can get to that point. And leadership at an organizational level, at a system level, is critical. But I think what we haven't done enough of is to link this to strong governance. You cannot be effective in these leadership roles, particularly when you're working on the 10-year plan, unless you have a governance perspective that also allies to this 10-year plan. So one of the, I think, real dilemmas and challenges we face here is that, as we all know, it's this year's target that is the most important, right? Not the view of the 10-year goal. And so we have to figure out a way to not ignore that, but to create organizations that are able to get a big picture, to focus on the long run if we're going to be able to achieve success. Thanks very much.
Thank you very much, Ross.